Hello, I am Valérie Villegrain, and I am very pleased to participate to the GABA Symposium at cTACE. I will talk about the future perspective for combined therapy, including cTACE. These are the most recent ESMO guidelines on the management of hepatocellular carcinoma, and you can see that they have changed recently, in particular regarding the systemic treatment. So there are first line and second line proposals, but as you can see also, there are no combination therapy, except the combination of atezolizumab and bevacizumab as a first line treatment for BCLC-C. So the outline is the following. First, we will see the current combined therapy, and then we will move to the combination with the systemic therapy. Let's start with the current combined therapy with the transarterial chemoembolization. First thing, TACE before or after surgical resection. We know now that the TACE before surgical resection has shown no benefit at all. Regarding TACE after surgical resection, it's still a controversial topic. The goal is to eliminate intrahepatic micrometastasis or residual tumor foci, thus preventing recurrence and improving patient survival. However, we could see drawback. It may impair hepatic or immunological functions. And I show here a meta-analysis including 24 studies with 9 RCTs and 15 non-RCTs, with a very large patient population. In brief, the results are there is an improved overall survival and disease-free survival among patients with multinodular HCC, HCC with a microvascular invasion or portal vein thrombosis, but there are no benefits in HCC larger than 5 centimeters. Overall, this combination is not included in the guidelines, and there is now high competition with the new drugs trial. What about the TACE awaiting liver transplantation? Here, there are two goals. If the patients are Milan in, the goal is to control tumor and to decrease the dropout rate. If patients are Milan out, it is to downstage the patient. I show here 2 studies with a conventional TACE before liver transplant, one from Irene Bargelini and another one from our group. As you can see, the study period was very different, and the rate of complete response also. That is clearly in relationship with the improved technical tips and tricks and the high selectivity and the use of the ConBeam CT that allow to increase the rate of complete response. It has been shown previously by Darren C. and colleagues that treatment selectivity increased tumor necrosis. So this is in line with what I've just said. And we can see here on the figure on the right that the selective TACE also has a significant overall survival compared to the non-selective one. So it means briefly that complete or nearly complete pathologic response improves long-term survival. Still, should we use TACE before liver transplantation? It is widely performed in most of the teams dealing with the liver transplant for HCC, but it is still debated. Actually, this is our first-line treatment in our center. Now, TACE combined with ablative therapy. The goal is to trigger tumor necrosis after tumor hypoxia. There are many articles. I want to show the result here of the meta-analysis of more than 2,000 people who were treated either by TACE plus radiofrequency ablation or TACE alone. They have shown a higher overall survival and recurrence-free survival with TACE combined with the radiofrequency ablation. there were no significant difference of complications between the combined treatment group and the monotherapy group, and the best results were obtained in large tumors exceeding 3 centimeters in diameter, which seems very logical. Yet, if we look carefully at the individual studies, the results are discordant regarding overall survival. We have to notice that there are few RCTs, and most patients were treated with hepatitis B, and these results might not be extrapolated to the general population of HCC patients. And such combination is not included in the guidelines. Now, what about the sequential TACE and portal vein embolization? It is clearly a very limited subgroup of patients who can benefit, because it is in the pre-op to induce tumor necrosis and increase future liver remnant of patients who are borderline resectable. Such combination has started more than 15 years ago, and a publication by Ogata from our group in a very limited number of patients already at that time, who were able to show a higher rate of tumor necrosis in the combined group than in the portal vein embolization group, a higher increase of the future liver remnant, and a higher 3 or 5 year survival. These results have been confirmed by 3 other groups, and including a large number of patients in the publication of PARC, and similar thing regarding tumor necrosis, increase of the future liver remnant. And therefore, such combination is not included in the guidelines, but I think it is a very interesting option in borderline resectable HCC. And this is an example of a large HCC in a patient with chronic liver disease. There is a large hyper-enhancing lesion in the right liver that shows necrosis. So the patient had first conventional TACE in the right liver. We see here the lipidal uptake on the CT performed 2 to 3 weeks after, just before the portal vein embolization. We can see here the catheter placed in the portal vein, and this is the result of the CT postoperative, when we see the marked increase of the future liver remnant. So interesting option, although in a limited number of patients. And we did observe a high rate of tumor necrosis in this patient. Now, the second part, which is less classical and more modern, this is the combination of TACE with the systemic treatments. There are 2 big groups regarding the systemic treatments: the angiogenics, that include the tyrosine kinase inhibitors or antibodies to VEGF. Why? The goal is to delay the tumor revascularization and recurrence after TACE. We know, and you can see on the figure in the left, that in cells suffering from hypoxia, what we observed after TACE, there are several mechanisms. One of them induce overexpression and overexpression of VEGF, as we can see here. It has been confirmed by measuring the plasma VEGF before the TACE here, or day 1, day 3, day 7, and you see that on D1, there is clearly an increase comparing to the pre-TACE. It has also been demonstrated by looking at the sampling, the tumor itself, in patients and in control, by looking at the immunohistochemistry using the CD34, which is an expression of the angiogenesis, and you can see on the right-hand side that there is an overexpression of CD34 after TACE. So then, combination with the anti-angiogenics would prevent this overexpression of VEGF and consequently the angiogenesis. What are the results? This table is adapted from the review published by Yovet recently. And overall, most of the trials that are shown here did not show any superiority by the combination compared to the cTACE itself, except one, which is the cTACE trial, where we see here that the progression-free survival was clearly different in patients with cTACE combined with sorafenib than in patients who were only treated by cTACE. However, we have to mention some limitation of the study. First of all, a modified PFS was a co-primary endpoint, and also it was a phase 2 trial. And therefore, combination of cTACE with the anti-angiogenics, either tyrosine kinase inhibitors or antibodies to VEGF, is not included in the guidelines. What about now the combination of cTACE with immunotherapy? The goal is to increase the efficacy of immunotherapy as cTACE, in particular using the doxorubicin, but also with other drugs, is an immunogenic drug. And on the figure we can see below, interestingly, there are several phenomena induced by the cTACE, and that could increase the efficacy of immunotherapy. We can see here increase in effector immune response cells, increased release of tumor antigens, and upregulation of PD-L1. A recent study from the pathologist working in our institution, the Montasser and colleagues, has shown interestingly what happens on a pathologic level. On the left, the samplings come from liver biopsy of the same patient before cTACE. On the right, this is the resection specimen after cTACE. And they have demonstrated that there has been an increase of intratumoral lymphocytes after cTACE, as well as PD-1 positive inflammatory cells, as well as PD-L1 inflammatory and tumor cells. So this clearly confirms the hypothesis that cTACE may increase efficacy of immunotherapy. This is an example taken from the literature when we see a patient treated with cTACE combined with immunotherapy. And you can see on the top images, the imaging findings showing a large heterogeneous tumor, and with 1, 2, 3 cTACE plus 1, 2, 3 immunotherapy treated several days after each cTACE session. The results are very impressive, where we see not only very important size reduction of the tumor, but also a complete tumor necrosis. So now the question is, why not using both cTACE with both VEGF inhibitors and immunotherapy? And the goal is to use the potential synergistic effect of combination therapy using either tyrosine kinase inhibitors or VEGF inhibitors with checkpoint inhibitors. The idea is the anti-VEGF therapies can reduce VEGF-mediated immunosuppression within the tumor and may enhance the anti-PD-1 and anti-PD-L1 efficacy. And the figure shows the action of the anti-angiogenesis therapy here, as well as the immunotherapy and the synergistic effect. So where we are, there are currently many trials. We don't get the result yet, and these results will be most interesting. I just want to cite two studies we have participated. The Emerald one, the enrollment has just been completed. It is the combination of anti-PD-L1 and anti-VEGF with the bevacizumab, with the 3 arms, with the both association and also the evaluation of TACE with only the anti-PD-L1, as well as a group with the TACE and placebo. It was mainly focused in BCLC-B HCC, patient having their first TACE, so as a naive patient, and it has been stratified according to the TACE technique, depth versus conventional, the geographic region, and the portal vein involvement. We have included 14 patients, so we are number 3 at a worldwide center. The second study we participate is the Checkmate. Here, this is a combination of anti-PD-1, the nivolumab, as well as the anti-CTLA4 and placebo. And again, there are 3 different arms. Both are indeed phase 3 RCT. And again, we are waiting for the results. It is certainly a very important topic, the idea of combining local regional treatment for advanced HCC with a systemic therapy. However, there are many different questions. Which agents? Should we do it in an adjuvant or neoadjuvant setting? Which combination of drugs? Which administration and which timing? So we have to work hard the coming years to solve all these different issues. So in conclusion, TACE, and in particular conventional TACE, is a very important treatment in HCC, not only in intermediate HCC, but at various stages. And there is a strong rationale for combining local regional treatment with the systemic treatment. There are many trials that are ongoing, testing multiple combinations. Today, treatment combination is mostly applied to advanced HCC, but it is very likely that such combination might move to earlier stage. And with that, I would like to thank you very much.